Welcome to today's explainer. Look, we've all been there, right? You're staring at a really complex clinical scenario, looking over a patient's symptoms, and trying to figure out exactly which strict medical guideline actually applies. Well, today, we're going to bridge that gap. We're going to take real-world clinical vignettes, decode the underlying organ dysfunctions, and directly link them to the specific, boxed medical guidelines you absolutely need to know. Let's dive in. Here's our roadmap for this explainer. 1. Fetal and placental anomalies. 2. Cesarean thromboprophylaxis. 3. HIV management in pregnancy. 4. Infant HIV prophylaxis. 5. Fetal growth restriction. And finally, 6. Pregnancy hypertension. All right, starting things off with Section 1, Fetal and Placental Anomalies. Okay, let's look at a classic vignette. Picture this. You've got a 20-year-old pregnant patient at 32 weeks, but her fundal height is measuring way ahead at 36 centimeters. Now, this immediately tells us there's excess fluid, right? Polyhydramnios. Then, the ultrasound gives us the golden clue, that distinct double bubble finding. And boom! As you can see, named right here below the ultrasound image, this brilliantly illustrates duodenal atresia. This is a primary fetal gastrointestinal dysfunction. Because the duodenum is literally blocked, that's the atresia part, the fetus just can't swallow and process amniotic fluid properly. This GI dysfunction directly causes the amniotic fluid to back up, leading to the polyhydramnios, which, of course, perfectly explains why our patient's fundal height is measuring so excessively large. Now, on the flip side, if a GI dysfunction causes way too much fluid, what causes too little? Well, check out the image here for Potter's syndrome. This represents severe oligohydramnios, and it's driven specifically by a kidney defect, like renal agenesis. Basically, if the fetal kidneys aren't forming or functioning, the fetus isn't producing urine, and the amniotic fluid levels just absolutely plummet. And, the physical consequences of that kidney dysfunction are incredibly profound. As a direct result of lacking that protective, expansive amniotic fluid, the fetus develops these really critical secondary dysfunctions. Specifically, we're talking about lung hypoplasia, because the lungs literally can't expand, and typical flat facies from actual physical compression against the uterine wall. It is a pretty stark reminder of how interconnected fetal development truly is. Shifting gears to the placenta, the specific structural anomaly you see pictured here is a succensurate lobe. This physical dysfunction carries immense clinical weight. If you spot this anomaly, you've got to immediately anticipate raised risks of postpartum hemorrhage, antepartum hemorrhage, and uterine subinvolution. Why? Because those extra lobes and connecting vessels are highly prone to tearing and leaving retained tissue behind. Moving right along to Section 2, Cesarean delivery thromboprophylaxis. So take a look at these box parameters. The crucial point here is memorizing these exact key values, because let's be real, they are surprisingly easy to miss in a chaotic, busy ward where you're making split-second calls. If a patient is undergoing an elective cesarean and she has even one of these isolated risk factors, say she's 35 or older, a smoker, has a parity of 3 or more, or preeclampsia, prophylaxis is immediately indicated, no exceptions. Next up, Section 3, HIV management in pregnancy. All right, let's put our diagnostic hats back on for a second. You have a 26-year-old newly diagnosed with HIV at her first antenatal visit. Her CD4 count is 550 and her viral load is 20,000. So the question is, how do these specific numbers dictate our immediate pharmacological response according to NACO guidelines? Well, if we look at the boxed key values from the NACO guidelines, the answer is actually really straightforward. Notice what isn't a factor here: CD4 thresholds. The guidelines strictly mandates that you start a triple drug ART regimen immediately, specifically tenofovir, lamivudine, and dolutegravir, and that is regardless of her CD4 count or her viral load. Treat all, start immediately, and continue lifelong. Simple as that. Which brings us directly to Section 4, Infant HIV Prophylaxis Guidelines. Of course, management doesn't just stop with the mom, right? We have to immediately apply prophylactic guidelines for the infant, and the management paths diverge sharply based on maternal risk. It all hinges on maternal viral suppression. If the mother's viral load was suppressed, the infant is low risk and gets a single drug, either nevirapine or zidovudine, for 6 weeks. But if she wasn't suppressed or was unmonitored, the infant is high risk. That requires a dual prophylactic approach using both drugs for 6 to 12 weeks. Okay, on to Section 5, Fetal Growth Restriction Protocols. Look, I know medical guidelines can sometimes just look like a massive wall of numbers, but these boxed ISUOG protocols provide exact, isolating thresholds that really bring clarity to the clinical chaos. First, we separate by time. Early FGR is before 32 weeks. Late is at or after 32 weeks. For early FGR, we are looking for very strict centile drop-offs, like an abdominal circumference or an estimated fetal weight dropping below the 3rd centile. But let's actually connect those numbers to the physical organ dysfunction shown right here. Underlying this is uteroplacental insufficiency. Notice the spiral arteries in the diagram. Increased pulsatility index, or resistance, in the uterine arteries leads to decreased blood flow. And that vascular resistance leads directly to early onset growth restriction. It's essentially a plumbing problem causing a major growth problem.
And finally, Section 6, Pregnancy Hypertension Definitions.
Let's wrap up with one last vignette. Imagine a prima gravida. Her blood pressure is 140/96. She is at 30 weeks gestation, and she's got +1 proteinuria. What exact category of hypertension does this fall into? To solve this one, we've got to rely on these rigidly boxed diagnostic criteria. You want to keep these crucial cutoff numbers firmly locked in your mind. Hypertension in pregnancy triggers at a BP of 140/90 or greater. And for proteinuria, we aren't just looking at dipsticks anymore. We look at the protein to creatinine ratio of 30 or greater, or the newer albumin to creatinine ratio of 8 or greater. So because our patient in the vignette had new onset hypertension at 30 weeks, which is well after that 20-week threshold, and she had proteinuria, she fits this definition perfectly. Ultimately, it's the addition of that proteinuria or other signs of end organ damage to pregnancy-induced hypertension that marks the dangerous transition into full-blown preeclampsia. Which brings us to the end of our explainer. But I want to leave you with this one thought. When you're studying these strict protocols, are you just memorizing rote numbers, or are you truly visualizing the physical organ dysfunction behind the rule? Because if you can connect that double bubble to the blocked fluid or that vascular resistance to the restricted growth, the guidelines stop being just random numbers on a page. They literally become a window into your patient's reality. So what do you think? Are you ready to look past the numbers? Thanks for joining me on this explainer, and keep visualizing the medicine.